Okay. Well, thank you all for joining us tonight. This is the first of our the Expert presentations for 2025. We have about six of these scheduled for the year. Tonight's presentation will be on intellectual disabilities and epilepsy. My name is Monica Anzalone, and I'm the Director of Programs and Services at the Epilepsy Foundation of Connecticut, and I will be helping to moderate tonight's presentation. There will be time for questions at the end of the presentation, and the doctor who will be presenting will be happy to answer those questions. Please type them in the Q&A section or the chat section at the bottom of your screen. But we do ask that you would just keep the questions pretty general as we're not able to give individual or personal advice during this time. So I'd like to introduce our presenter. We are joined tonight by Dr. Mark Schomer. He is a pediatric epileptologist at Connecticut Children's. He's also an assistant professor of neurology at Connecticut Children's, UCONN. So Dr. Schomer.
All right, so welcome everybody. Thanks for joining our talk tonight. So as Monica said, this will be the inaugural talk for the year. And I'm starting it on epilepsy and intellectual disabilities. So, we're trained to give goals and objectives at the beginning of our talk. So I just kind of wanted to put in a few specific ones that I'm hoping we'll kind of get through before the end of this. So first, I'm just going to outline briefly normal developmental milestones and what are some red flag symptoms that parents can be on the lookout for their children once they've received an epilepsy diagnosis, if they're concerned that there may be some intellectual disability. We're going to talk briefly about developmental screening tools and when those tools should be utilized normally at doctor's visits, whether it's with the pediatrician or with a specialist. I'm going to give a couple examples of how neurologists specifically can help modify some of the intellectual disabilities in various of the forms of epilepsy. And then I have a listing of resources for parents of children who do have this combination of diagnoses. So I wanted to start with, this is a set of questions that was developed by Orrin Davinsky. He's one of the epileptologists down in New York University, and he's been very active in this field for some years. And this is from a paper of his in 2015. And unfortunately, I think we're in very much a similar state in terms of where these questions lie. But this is kind of where I think that we can think about where neurologists and the parents of patients can kind of interact. So number one, how can we improve the education of healthcare workers about intellectual disability with epilepsy? Two, can we better define the epidemiology and the risk factors for comorbid disorders? So things like autism spectrum disorder, anxiety disorder that we know occur very frequently in children with this combination of diagnoses. Can we adapt investigative and diagnostic services to enhance the access to care? Can we help ease the burden of caregivers? Can we improve the accurate diagnosis of syndromes and complement these with genetic investigations? Should we apply specific medication recommendations, dietary recommendations, and surgical assessments, all for the same indications and extent as in epilepsy patients without intellectual disabilities? Should there be a difference in terms of how we think about these people? How should we measure physical, cognitive, and behavioral side effects of epilepsy, and specifically epilepsy drugs and surgical therapies? Are the psychiatric classifications and diagnostic criteria valid for what we do? Does psychiatric care resources actually meet your needs and provide the expertise needed for care? And is research to assess and treat these patients commensurate with the problem? So this is just a broad overview of how we think about epilepsy and neurology. So I don't mean by any means for people to kind of get everything from this. We're going to be focusing over here on the left side in comorbidities, right? So common comorbidities of children with epilepsy include things like intellectual disability, autism, anxiety disorders, depression, and these can become magnified as they become older and more aware of their diagnoses. So a child has a first seizure. It could be focal, it could be generalized. Maybe the parents can't describe it well enough. Maybe the neurologist doesn't know exactly what it was. That then, once that has happened, we move down to try to define that epilepsy a little bit better. So there are epilepsy types then. They're focal, generalized, combined types. And more importantly than even those generally is the etiology or the cause for somebody's seizures. Those can be structural. It can be a problem with the brain, the way the brain was formed. It could be a tumor, something along those lines. They can be genetic causes, problems with the way the brain is regulating the flow of electricity through ion channels. It can be infectious causes, which may cause structural injury. It can be metabolic causes, the way your brain is processing glucose, for instance. It can be immunologic causes, or the unfortunate etiology is 50% of the time we're left with an unknown cause. We still don't necessarily know. Now, once you've put all that together, then we try to give a child a name of what's the epilepsy syndrome, if possible, of why are their seizures happening and what do we expect for them for the future? And most importantly, how can we help reduce the seizures and help their development? So the reasons that epilepsy can interact and either cause intellectual disability or occur at the same time as intellectual disability, there's a lot of factors, right? So we start here in the middle with this is your cognitive function. This is somebody's baseline, how they're able to understand the world, how quickly they process information, how they're able to work with multiple things at a time, right? So first we take what's the reason for their seizures, and whether or not this is a known seizure disorder. And then we think about how does that actually alter the network within the brain that you rely on to, say, control executive function, right? Somebody with ADHD may have impaired structural or functional connectivity into the frontal lobes, causing executive function and inattention, right? Then once that is complete, there's all these other things that can influence their cognitive function. This is anti-seizure medications, many of which are known to cause various cognitive issues. There is epilepsy surgery, which I'll touch on very briefly later. But this can either be good or bad for cognitive development, depending on the patient and the surgery done. There's somebody's baseline genetic background. Remember, I mean, somebody's cognition is usually going to be somehow related to their parental level of cognition. And then what's the environment and background that they're raised in? As we know that intelligence and cognition and all that is very fluid throughout a lifetime. And this is the entire purpose of the school interventions and such, of how do we help a kid kind of achieve their maximal potential. So some of the developmental milestones, you'll see I've highlighted here in red ones that we think about more when we're thinking about intellectual disabilities specifically. So there's lots of developmental milestones, and some of you may have had children who received a diagnosis of a developmental delay. That's a very non-specific term, which can include fine motor problems, can include gross motor problems, can include purely social problems, such as the child with autism who has no intellectual disability. But when we think about the developmental milestones, typically it's these receptive and kind of expressive language milestones that are the most important. So how does your child understand what is being said to them? Are they able to process that and then respond appropriately? So this changes obviously with age. Around 4 months, what we're looking for is basically responsive smiling. Does your kid coo when they're happy? Do they make these noises of excitement? At 6 months, are they starting to recognize that when they look in the mirror, that's not another person? That is the kind of sense of self that they're developing, that this person in the mirror actually is me. At 9 months, are they starting to understand the word no and some very basic commands from their parents? At a year, are they playing peekaboo? This is something called object permanence. This is the brain's ability to understand that even though something is no longer in your sight, it still exists. Kids take a lot of pleasure from that, and they'll play peekaboo because they've just finally understand that their parents didn't disappear when they hid behind their hands. Are they able to follow simple directions like put that down? At 18 months, are they able to speak and understand at least several words? 2 years, are they noticing when other people are upset? Are they combining words together into very simple phrases? And then by 3 years, are they able to name pictures of common objects and recognize labels and colors to things? So then you go to the red flags. These are the things that we're all on the lookout for. I'm guessing most of the people here today are parents. I'm one as well. And one thing you're always worrying about is making sure your kid is on track. Are they doing things at the right stage? Because what we do know is that if you intervene early, you can really help them far more than if you wait for too long before interventions are given. So by 12 months, a big red flag is a kid who's really not making much noise at all. They're not making ba 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 sounds. They're not babbling. They're not trying to speak. So babbling is technically kind of when it sounds almost like a foreign language. It has inflections and tones to it. They go ah da ba ba ba, and they go up and down in their inflection, and they create different sounds as if they're trying to form words. Are they waving, clapping? This is very dependent on how often parents do those things too. So if the parents don't wave at the kid, they're not going to learn to wave as a response of hello or goodbye, but very similar gestures that are routinely done within the household. Do they respond to their name? Absence of any of these things should prompt a referral at least to the pediatrician to kind of start doing the workup to see if there is a developmental delay. At 15 months, are they not using any words? Are they not responding to words like no or up, meaning wanting to get picked up? And then for, the autism screening and kind of social emotional type things, are they pointing? Are they trying to share attention? So this would be if a child, say, finds a fun toy. It's one of these light up toys that you press and all of a sudden starts spinning and flashing. That will be super exciting to most 15-month-olds. But if they're excited, do they then try to show it to their parents? Do they want to get them excited at the same thing that they're enjoying? Absence of these things, again, should prompt at least a basic investigation by the pediatrician. And remember, not all of this means that your child will have an intellectual disability. It could mean if they're not speaking, it could mean they have a hearing problem. They should have their hearing tested. So these are by no means diagnostic. They're simply things that mean you need to pay attention to this. By 18 months, do they follow simple commands? Are they not using at least 20 words? And do they not know at least several of their major body parts? And then the easier to remember one is by 2 years, they should really be combining two words together, like mommy go, take out, things along those lines. It doesn't have to be a full sentence with subject, object, verb, noun, all of that. It just has to be they're trying to put words together to express an idea that you can't get with just a single word. Um, sorry. Um, are they saying fewer than 100 words, and are they not imitating any actions? Because children learn through imitation. So the absence of that would make you concerned again. So then you can take all of these developmental milestones, and I'll show you how we do that later, and you put them into basically degrees of developmental delay, which is measured as a functional age, right? So a 2-year-old who has a functional age of 18 months would have basically, that's a 24% difference. So they are functioning in the mild developmental delay range, okay? If they're functioning like a 1-year-old when they're 2, that would put them into a moderate developmental delay stage. And these are all helpful, again, for helping determine in the future, what kind of help are we going to need to offer this child? So these are developmental screening tools. I just put a sample of what some of them are here. And these are things that should typically routinely be done at the pediatric visits. And you can see a kind of standard screening here. So at 9 months, the ASQ, that is the Ages and Stages questionnaire, should be done. And you'll see that that is the one that stays stays consistent throughout a childhood, essentially. The Ages and Stages questionnaires vary early on every month, and later on every 3 months. So you would have a different questionnaire for a 24-month than a 27-month-old child. These should then, if there are concerns, they can refer you on either to a neurologist or to a developmental pediatrician, both of whom can do more testing. I'll say when it comes to the questionnaires and screening like that, neurologists tend to do far less of this than developmental pediatricians. And so if it's purely a question about development without any other issues, that will often be dealt with kind of outside of the realm where I practice, okay? And then we have things like the PEDS, which is the Parents Evaluation of Developmental Status, as well as the MCHAT, which those of you with older children will be familiar as it's given almost across the board to every kid at 18 months or 24 months now throughout this country. And then this next stage, I just want to give you a sample of what some of these look like, right? So here's a sample of one of the pages from a 27 months Ages and Stages questionnaire. So this should be something that the pediatrician will do if there's suspicion that is raised. And it's simple things such as without giving him clues by pointing or using gestures, can your child carry out at least 3 of these kinds of directions? And then you as the parent fill it in, say, yes, they can put the toy on the table. Would they do that? Sometimes, not yet. all of this is taken and basically put into a score so that we can come up with what I was discussing earlier, one of those developmental ages for the child. And then this is a sample of the MCHAT, which is a very short questionnaire that is by no means diagnostic for autism, but it helps you determine when do they need to go to the next stage of testing to see if this is somebody who may have social anxiety that's being confused with autism or some other disability that is making it so that people think that they look like they have autistic behaviors or traits. As your child gets older, if there are concerns, these are things that might be administered by the school system. So if your child is in elementary school or above, if there is concern from the school or the parents, we'll talk about this in a little bit, they can request neuropsychiatric testing. So the schools are able to bring in neuropsychologists. We have a number of neuropsychologists at Connecticut Children's that we work with now, specifically focusing on children with epilepsy. And there's also a couple private groups around that we have worked with historically in the past that are very good too. But typically, if your child has a comorbid diagnosis, meaning they have epilepsy and concern for a cognitive issue, usually this will be covered either through insurance or it will be paid for through the school system. And they can administer what is called the WISC-5 or WISC-V, which is basically the Wechsler Intelligence Scale for children. And this is used to determine all the different subsets of what goes into what we think of as cognition. And I'm sure everybody here probably feels similarly, which is IQ is a horrible score. It changes based on race, education level, country of origin. There's lots of things that change how your IQ will be measured. And so it's a very gross measure. And this really is only valid specifically for native English speakers, like I said, between ages of 6 and 16. And what it does is it tries to break children down or break people down into the different domains of functioning. So verbal comprehension, visual-spatial comprehension, fluid reasoning, working memory, and processing speed. And then it will assign based on the test, a percentile rank, which is then used to calculate the actual, as it's called, full-scale IQ test, full-scale IQ. So where are we talking about, right? So we're talking about full-scale IQ and intellectual disability. Technically, what that means is you were referring to people down here at this end of the bell curve in terms of their cognitive function. So this is a normal bell curve. Those of you who remember kind of algebra and such will see that these are standard deviations. So the way an IQ score is arranged is every 15 points is one standard deviation. So normal IQ, average IQ for people is considered 85 to 115. That is basically one standard deviation from the norm, which is about 2/3 of all people. Then another standard deviation on either side. Once you have from here all the way, here all the way to here, that's about 95% of all people. And now you're talking about people with an IQ below 70 or above 130 only represent the other 5% of all people. So when we're talking about this comorbid condition, we're talking about people in general. Most children with epilepsy who have an intellectual disability will fall within the mild range. And we'll talk a little bit about how that kind of changes based on the severity of their epilepsy. But this is going to be the vast majority of people that we're talking about here. So what do these really represent in terms of how people function and what they can learn, right? So a mild intellectual disability, which is an IQ from 50 to 69, represents about 85% of people who have intellectual disability, period, right? So these kids are often not identified until they begin school, and some of the expectations of what they have to do get more and more. They are generally considered capable of learning, reading, math, writing, all of that. Oftentimes, they'll kind of plateau around the things that you would expect somebody to be learning towards the end of elementary school, middle school. So think like multiplication, division. They can do all of these things and take care of themselves. They could balance a checkbook if they wanted to. And they are totally capable of doing things like self-care and all these practical skills. And with the right help and assistance, many of them are able to live independently and maintain employment and lead normal, meaningful lives for themselves. Um, Moderate intellectual disability is a different ballpark. This is 35 to 49% of people. And it is often much more obvious within the first few years of life. A lot of these children will have more clear kind of receptive language problems, expressive language problems. And really what this means is that as they get older, they're a lot more likely to need extra support in their lives. So these are the people who may need a supportive group environment. They might be able to live semi-independently with somebody else who helps them with things like taxes and things like that that take a lot more concentration. And this represents about 10% of all people who have an intellectual disability. And then you have the farthest end of the spectrum, which is severe intellectual disability. These people, with almost without fail, will require significant intensive support and supervision throughout their entire lives. The numbers down here get very vague and hard, and truthfully, that's true of moderate as well, where a full-scale IQ that's given to somebody, it's hard enough to do the testing for them that these numbers are very variable, and they mean less and less the further you get away. So then what do we know about how this impacts people and their epilepsy, right? So what we do know is that about 20 to 25% of people with intellectual disability have epilepsy, and this goes up. So the more severe form of intellectual disability, the more likely they are to have epilepsy. And conversely, about 20 to 25% of people with epilepsy also have an intellectual disability. And this is the same story, which is the ones who have more severe epilepsy or intractable epilepsy are more likely, you can see as a percentage, to actually have severe or profound intellectual disability. And the same thing is true with both all epilepsies or focal epilepsies, although there's a little bit of wiggle room kind of down here in the normal to mild intellectual disability. But what we can pretty clearly say is the more severe your intellectual disability, oftentimes the more severe the epilepsy, and the more severe the epilepsy, oftentimes the more severe the intellectual disability. So how do we help this, right? So first step should always be schools. These are for all children under 18, essentially. And this is the big question for most parents in the initial planning stages of what's happening, which is, do they need an IEP or a 504? And the big breakdown between these two is that one, an IEP is an educational law and a 504 is a civil rights law. So that is basically saying the school needs to give accommodations because of a medical problem. The IEP is the school giving accommodations because of a learning disability specifically and not some other diagnosis, okay? So you can take the child who has normal cognition but ADHD. Most of them would qualify for a 504 where the school gives them supports like sit closer to the teacher, fewer distractions for taking tests, more time to take tests, things along those lines. But we're going to be focusing more on these children. Both of these, the IEP and the 504, can be requested by the parents. And in order to qualify for an IEP, typically what they'll have to do is they'll have to do actual psychological testing, the neuropsych testing as we were showing earlier. And on a national level, in order to qualify, they would need a diagnosis of a mild intellectual disability or more severe, okay? So then what can we as neurologists, right, do to help prevent or help treat any of these forms of intellectual disability? So there's a couple specific things that are what we in neurology consider red flag symptoms or red flag issues that we should basically focus on as quickly as possible, because the way we think, it's almost like with a stroke, which is time is brain. The sooner you intervene and the sooner you can treat what is causing some of the disability, the more likely that child is to have a good outcome and have a normal life that free of disability as they get older. So this is a sample EEG. Again, some of you watching may have had children who had infantile spasms. This is what is called hypsarrhythmia. So this is, if you look at it, just a mess of squiggles, right? Most of you here have probably seen EEGs in the past of your own kids or in some form, and they don't look like this. You can see discrete lines going across. So this is what we call high voltage or high amplitude disorganized activity. If you zoom in, you'll see that this mess of activity is actually in general individual spikes coming from all regions of the brain, all at different times, all right? When we see this as neurologists, it is essentially a medical emergency. Usually infantile spasms are typically going to occur in about a 4 to 12-month-old age range. They can occur in kids who you were expecting something to happen because they had bad seizures when they were born, or they could occur in a child who has up until that point been completely normal. Basically what you look for is clusters of kind of flexion. So it looks like, the easiest way I try to explain it to my patients is, imagine someone just punched your kid in the stomach. They go like this. It lasts only a second or two, but it often happens over and over and over again, what we call a cluster. Now, when we see this, our goal is to treat it as soon as possible. So what we have shown is, this is done through lots of different studies, which is kids where we do not find a cause for their infantile spasms, and those who we treat the spasms quickly, are the most likely to have normal development in the long term. Okay. So when any parent should be hoping for is that we don't figure out why your kid's having spasms, right? About 80% of kids where we don't find that cause have completely normal development at 5 years old. So we're talking many years after the spasms have gone away, but it can take many years to completely catch up. And what happens if you don't treat these infantile spasms or that EEG background is that you can actually suffer a developmental regression. That means that you have lost milestones. The child who was babbling all of a sudden stops babbling. We'll often see they become very withdrawn or irritable. They're not making eye contact like they had before any of this. And if we can treat that, we can change the entire course of a child's life and make them have completely normal development. And that's what we're always hoping for. So it's interesting that, we know this about infantile spasms in general. There is another totally separate condition that is one of the most common causes of infantile spasms, called tuberous sclerosis, which is basically a genetic condition that causes overgrowth of certain parts in the body. It's kind of like a cell regulation gene that causes things to be overexpressed, to grow too quickly or to grow too large. And part of the clinical syndrome that is tuberous sclerosis is infantile spasms. There was a really wonderful study done at Boston Children's a few years ago, basically showing that if you took kids who you knew had tuberous sclerosis and you prevented them ever having spasms by treating with anti-seizure medications, specifically something called vigabatrin, that you would actually be able to prevent the spasms. But unfortunately, what it showed was that these children actually had the same developmental outcomes as those who you didn't treat the spasms. So it's almost like it was a predetermined thing that it was going to happen, or there's something else going on, which is very different from normal infantile spasms, where we can say, if we treat this, we can potentially normalize things for that child. Then we have the other main epilepsy syndrome that we think about in terms of a modifiable epilepsy syndrome, which is something called electrical status epilepticus of sleep. This has been given tons of different names over the last 10 to 20 years. It's been known as continuous spike waves of sleep. It's been known as Landau-Kleffner syndrome. I always tell people that if a bunch of epileptologists get together and they don't have anything else important to discuss, they just go around and start renaming syndromes, which is why we have like 10 different names for everything in the book. But what this is when a child who may have never actually had a clinical seizure in their lives, they start developing some form of developmental regression. Landau-Kleffner is usually specifically language regression, meaning you take a 5 or a 6-year-old who was speaking in sentences, they were coming home from school and telling you what their day was like, and all of a sudden they're fumbling over words, they are forgetting words, they're not able to form sentences clearly anymore. That there's kind of two main things that cause that typically in childhood. One can be what is called autistic regression, which is a child usually between 3 to 5 years old who has autism will start losing some of their milestones as part of the kind of normal progression of an autism spectrum disorder. That there's nothing that we know of that will specifically fix it, but it should in general prompt the neurologist to do an EEG, because if we see this pattern here, which is spike, 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 during what is called non-REM sleep, then high doses of steroids intravenous immunoglobulin or specific anti-seizure medications can actually suppress the activity. So the classic treatment was to give really high doses of Valium at night that would basically suppress all this abnormal electrical activity. And if you think about kind of how memory is formed and how the brain functions, if you're slow wave sleep, that is the restorative sleep. That is kind of when your brain is getting rid of all the junk. And more importantly than that, for this, consolidating everything that you learned for the day into memories. If you're interrupting that with continuous electric discharges, then you're not getting the normal function of what sleep is supposed to do for you. So by suppressing this, it's been shown multiple times that you're actually able to improve somebody's kind of developmental trajectory and get them back on track. This is often a short-term thing that may last only for 3 to 5 years or so, but do you really want to sit for 3 to 5 years as the child has regression when you know if you could give them a medicine, you might be able to actually speed things up in terms of their recovery from what has happened? And then this is the other main modifiable thing that we can work on for if someone's having cognitive issues. And this is probably the most common that we see, which is the medications we give for seizures. We know as neurologists, everyone who prescribes these medicines is well aware that they can slow people down. There are specific ones that we think of as having very specific effects, like topiramate, TPM, will cause word finding difficulties very commonly in people. It also causes other kind of processing speed issues for people. And this basically is a chart from a nice study back in 2008, where it's what's called a meta-analysis, where they looked at all of the different studies that have looked at similar questions and try to group it together so that you can kind of get a much bigger picture rather than just one study that compared valproic acid, carbamazepine, and phenytoin, right? This study tried to put them all together and say which ones have actually been shown to clearly cause developmental problems or cognitive slowing for people. And I think the key takeaway from here is the only ones that haven't really been shown to cause significant issues are levetiracetam, Keppra. Now, those of you who have children with epilepsy realize this is very, very commonly prescribed. It has other issues besides cognitive issues like mood issues and irritability and anxiety and such, but it doesn't necessarily make their thought processes slower. And then the other this is what is the best tolerated medicine in all of epilepsy, lamotrigine or Lamictal. Lamictal is the only one that's actually been shown. Sometimes they put an up arrow here for Keppra, but sometimes actually as it can help cognition or at least cognitive kind of processing speed for people. So if you have a child who's on any of these medicines and as you go up, you notice they seem slower, you notice they're more withdrawn, they're not speaking as much, they're having more trouble, that's definitely something to talk with your neurologist about and see what else can we try. Would a lower dose help just as well, or would a different seizure medicine treat the seizures just as effectively without these same side effects? And we always try to take these side effects into account when we're deciding which medicine is best for a kid. But sometimes it's more trial and error than anyone would really like. Okay. And then the very last thing is epilepsy surgery. I put this very briefly because the jury is really still out on how epilepsy surgery helps with cognitive function. This is just a selection of recent papers that are all very gung-ho for epilepsy surgery. So epilepsy surgery for cognitive improvement in epileptic encephalopathies, children with mild malformations of cortical development with improvement in cognition, and then cognitive outcomes after temporal lobe epilepsy surgery, which is the most common form of epilepsy surgery. I remember back when I was actually a pediatrics intern and I was giving a talk on why I wanted to go into neurology specifically to some of the other pediatricians there. I specifically focused on this, and that was about 15 years ago. And the point at time then, there were about 2 articles showing that early intervention with epilepsy surgery for children who had intractable seizures, that it improved their developmental quotient, meaning it helped them get closer to where you would think that they would be for age. That's been refined a lot more over time. And what we're starting to realize is that um, smaller resections that are curative, meaning if you're able to actually stop all the seizures, are the ones that have the best outcomes. And the other children who have the best outcomes are ones who already had very minimal cognitive effects. The children who have severe intellectual disability and get epilepsy surgery are less likely for you to notice a really huge improvement. And if you think about that globally, a severe intellectual disability implies that there's multiple regions of the brain that aren't functioning properly versus somebody who might be measured as having a mild intellectual disability. It really might be specifically a problem in language. Maybe that's just coming from their left temporal lobe, and that seizures are just interrupting their development of that one aspect of their cognitive abilities. And with that, I wanted to leave you with a few resources. So these are ones that I have had help with my patients. That, of course, I'm going to put the Connecticut Epilepsy Foundation here. But some of these ones here are all well-validated resources that can help you find services. I always want to put in a plug for Birth to 3 here, which is that a lot of parents come in and they ask for a referral to Birth to 3. Now we can put a referral in, but anybody can refer to Birth to 3 if there is concern for a child's development. That can be the teachers in the school, that can be the parents, that can be concerned friends of the parents. Anybody can put in referrals, and these services are always going to be free for the evaluation and for the treatment. And so getting an evaluation if you're worried is the best first step so that we can come up with a plan of how to help. And then these are specifically, in most cases, schools for children with more significant intellectual disabilities that will also help children who have comorbid issues, whether it is autism or epilepsy or something like that. Okay, and I'm just going to leave that page up for anyone who's interested. But I'm now going to leave that open just to see if there's any questions that have come in.
Thank you, Dr. Schomer. And I'm going to give people a few minutes. We do have one question in the Q&A, but we'll give people a few minutes to type. I do want to start by asking, so would you say that then intellectual disabilities are not one of the known causes then for epilepsy? So I guess I heard that the brain or the brain abnormality that causes the autism is also what then causes the epilepsy. Um, so is that not the case then? Is it because I see that you put it in the comorbid side of things rather than the far right side where you had the etiology?
Right. So, I mean, if you go back and look at the statistics, right? So the more severe the intellectual disability, the more likely they are to develop epilepsy. I actually had my fellowship advisor back when I was training to be an epileptologist. We had spoken about this because we had put out a paper on basically on that surgery question of which kids do best with epilepsy surgery and development. And we were surprised kind of to see that the kids who had the lowest scores on their full scale IQ testing had the worst outcomes in terms of improvement. We thought, well, there's more room for improvement, so that will potentially help these kids more. But it was the exact opposite. And the way we think about it neurologically is that having a more profound intellectual disability points to a more global dysfunction of the brain.
Mm,
So if you think about kind of what's epilepsy, right? Epilepsy is at basis a failure of the brain to suppress an abnormal discharge or an abnormal rhythm. So it's a failure of inhibition in most cases, or a failure of too much excitation. But in a lot of cases, it's inhibition. So if you're not inhibiting those abnormal impulses, you also may not be inhibiting the ability to, like, all the different impulses that come in that want to steal your attention, right? So that's ADHD. You can't inhibit the door opening over there, the car driving off outside, even if you're trying to give a talk to the Connecticut Epilepsy Foundation. So I think of it as more that they are interlinked, absolutely, but one is not the cause of the other,
mm,
except in those cases of kind of the specific syndromes I showed, like infantile spasms or electrical status epilepticus of sleep. In those cases, the epilepsy is the cause of the intellectual disability, and that can be modifiable.
mm,
But I don't think there's much showing that the intellectual disability will cause an epilepsy, but it
mm.
occurs in the same people very
Yeah. Okay. Thank you.
absolutely.
And I actually had this question too. One of the participants tonight is asking epilepsy and meds could cause intellectual disability when seizures are controlled. Do you see any evidence that the IQ will increase?
Um, IQ will change almost on a test by test basis, absolutely. So if someone's attention, so that's a classic one. So we use a lot of medications that may sedate your kid, right? It may not actually be dropping their ability to process information, but because they're sedated, say they're on phenobarbital or clobazam or something that at higher doses might make them just feel kind of sluggish, they're not going to do as well on IQ testing. And so they will look like somebody who has a more profound intellectual disability than they actually do. Almost always those are reversible. So if you take the medicine away, the person who was taking that medicine goes back to their functioning that they were at before. But if you took an IQ test when you were not on a medicine, say you're only on Keppra, you take an IQ test and you get one score. If you then get put on a medicine that makes you just feel slower and more lethargic, that will drop the test scores and make you look like you have a lower full scale IQ. Absolutely.
And in that case, would you say then that the epilepsy is causing the intellectual disability? Would that be one of the situations?
Well, that would be another situation where if they did not have an intellectual disability beforehand, before they had seizures, then you have to look at all of the other information to decide if it's the epilepsy causing it, right? So that is where EEG can be very, very helpful to us. So there's a subset of epilepsies called the developmental epileptic encephalopathies.
Mm,
So these are things where the discharges that are happening in the brain are happening so frequently that they are actually causing you to have a more profound intellectual disability.
mm,
That is separate from basically genetic epilepsies that have an intellectual disability, where it might just be the way the brain was formed. Some of those synapses didn't form properly, or some of these signals are not getting to the right place where they should. That can be when they're kind of shared intellectual disability and epilepsy. But there are cases like infantile spasms and ESES where the epilepsy is causing the intellectual disability. And usually what you'll see on the EEG in those cases is lots and lots and lots of spikes
mm,
happening, whether it's only in sleep like ESES, or if it's happening all the time during the day, like things like Lennox-Gastaut syndrome.
mm. And Dr. Schomer, there is another question. Do you want me to read it for you, or do you prefer
Yeah,
to read
please.
it?
I don't have the question
Okay.
showing up. I have this screen view.
Okay. Okay, so this is a parent of a 24-year-old son with autism and an intellectual disability. He has a IQ of 59.
Okay.
He had a seizure 2 years ago, which was preceded with sleeping issues. The seizure is under control, but they've noticed memory issues, irritability, anxiety, and behavioral self-injurious behaviors. So how do I get some of these concerns under control?
Okay, well, so that's a lot. I mean, I'll say it's hard without fully evaluating in terms of what's happening with your child's EEG and such, as well as all the other issues. But remember that there's always going to be multiple things that play into how someone's memory or function is appearing at that time. So if his anxiety is out of control because he had a seizure and now he's anxious about seizures, well, that might play a role into how he appears to function. Kids with severe anxiety often appear inattentive because they're so focused on their internal world of what might go wrong, right? So that could be one thing. He had a seizure a couple of years ago. Did they change his medications? Could that be influencing how he now appears in terms of his mental processing? The medication might be partially at fault. Or was that seizure the herald of something really changing in the way his brain functioned? And then you would often expect to see some difference in the EEG with either more spikes or different locations or more frequent subclinical seizures or something like that. So there's a lot of different possibilities in that scenario of what might be causing your son's issues. I would definitely say that's something that should be teased out with an epilepsy specialist to see if there's anything they can do to actually help.
Hmm. All right, we'll just wait another minute or so. If people have further questions, feel free to type them. I know this is can be very challenging, I'm sure, for families to have, to deal with even both diagnoses, and to know how to best help their kids. Oftentimes we do get calls with just people wanting direction in these areas. And as you mentioned, I mean, it is the neurologist, the specialist that is working with the child that is going to be the first person. But then Dr. Schomer has some great resources here. Certainly take a look if you'd like more information about any of them. I'm sure we can point you in the right direction.
Yeah. For the last questioner, I would point them for a 24-year-old. This group, Futures Inc., can really help a lot of times, as they were actually founded by a parent who had a lot of issues trying to find the correct resources for their child who had a kind of similar picture of what you're describing. Once they made that kind of transition from teenage years into young adulthood, which is oftentimes, I think, for a lot of parents, one of the hardest transitions that they make, because you're stuck trying to figure out, you no longer have those school supports. You no longer have them going to school during the day, being watched, being taken care of. And now they are out on their own and you're trying to find the right place for them where they can still thrive. And that, I think, is one of the big gaps that we have, in terms of caring for children who have intellectual disability, is how do we help them once they age out of the school system at 22?
Right, right. And we have done webinars specifically on that topic as well,
Yeah.
particularly about transitioning um, from, school age to beyond. And so if people are wanting help in that way, also we can definitely connect you. There are some great supports in the state of Connecticut for that. And then even certain schools that might be helpful. Okay, and then one question, where do we find an epilepsy specialist in Connecticut?
What's the age of the child or the person?
I believe it's 24 as well.
24.
Yeah.
I'll say the group we work with most closely, just because we're in Hartford, is with Hartford Healthcare. They have a good group of adult epileptologists. There is a growing group of adult epileptologists at UCONN, so in Farmington. And then Yale has a world-renowned epilepsy group as well. So I think being in Connecticut, there's a lot of resources,
Mm.
thankfully, for people with epilepsy. And most of the time, you're going to find them at large centers, because epilepsy is one of these things that takes a lot of different cooks in the kitchen to try to help people as much as possible. And oftentimes, you'll rely on the resources of kind of a larger hospital system.
Right. And just, I guess, a last question. So have you noticed, just in your time as a clinician, have you noticed there being an increase in these comorbidities? Like with your patients having both of these conditions together? Has there been an increase? I know that generally, like I've heard this, like a third of the population that has epilepsy also has an intellectual disability. You said 20 to 25%. So I think that's pretty about the same, right?
Yeah,
Has
it's,
that changed much?
things always depend on which study you're looking at, correct?
Yeah. Okay.
But has there been an increase? I can't say that I have specifically noticed an increase. I think a lot of it has to do with the attention paid by the primary care doctors. So we are getting a lot more referrals for first-time seizures in kids who may be developing epilepsy.
Mm,
And I think what that speaks to is that there's a lot more awareness out there in the community, especially things like infantile spasms. I mean, it used to be, when I was even just first coming out of residency, it was a not unknown condition by any means, but it was not people's first thought when a kid was having those movements necessarily. But nowadays we have the pediatricians and people taking care of kids that age so alert and aware, I think, that most of the time we're getting them into the hospital and getting diagnosis and treatment within days of the spasms starting, which
mm,
is actually making a huge improvement, I think, in terms of how these kids do with their long-term outcomes.
mm. That's great. All right. Well,
All right.
this has been recorded and we are going to make this available on our website. Hopefully we'll have this up on our website by next week. If people, again, have further questions, please reach out to us. We can help you get those answers. That's part of what our office does, is provide information about epilepsy, connect you with resources, and even connect you with doctors in certain situations if you don't already have an epileptologist. So, um, okay. Well, thank you, Dr. Schomer, for your time and this presentation. And thank you for everyone for joining us tonight. And we look forward to our next series, which will be, or our next webinar, which will be in March.
All right. Thank you very much for attending, everybody.
Good night.
Good night.